A very good morning, dear doctors. Welcome to AiMedTech, and today we are going to discuss on the previous year multiple choice questions from different NEET PG entrance examination. And our today's topic is on medicine. As you all know that medicine is one of the most difficult and high weightage topic in NEET PG. As per as our last data intelligence report, it has been given the maximum weightage. We have recently released the data analysis related to the NEET PG preparation, and those who yet to go through that particular video, see the video and you can get your proper guideline related to your NEET PG entrance examination. So let's start our session. The definition of fever of unknown origin includes all of the following except option A, undiagnosed after 1 week of investigation. Option B, immunocompromised status should be ruled out. Option C, temperature more than 38 degrees centigrade. And option D, fever persisting for more than 3 weeks. So go through the option carefully and then answer the questions. Here the right answer is option A, that is the undiagnosed after 1 week of investigation. You should know the modified diagnostic criteria of FUO. Yes, it comprises of fever or temperature more than 38.3 degrees centigrade or more than 101 degree Fahrenheit on several occasions. Next, that is the duration of the illness persisting more than 3 weeks. And the third part, that is the evaluation. No diagnosis reached after 3 outpatient visits or 3 days in hospital investigation. So here is the catch. If you differentiate between the old criteria and the new criteria, that is the FUO criteria evolution, you can see that the previous criteria established by the Petersdorf and Vision in 1961 has been modified in modern practice. Why? This is to reflect the outpatient management capabilities. Yes, the modern healthcare emphasizes the outpatient workup so that the requirement has shifted from 1 week to 3 outpatient visits or 3 days in hospital in current criteria. So this is the catch to answer this question. So here you can see that option B, it is also a part of the actual definition of fever. That is the immunocompromised status should be ruled out. Yes, we can see that. We know that there are 4 categories of FUO. That is number 1, classic FUO. Number 2, nosocomial FUO. Number 3, neutropenic FUO. And number 4, the HIV associated FUO. And neutropenic FUO and the HIV associated FUO are associated with immunocompromised status. So therefore, the option A is the right option in this case. So you should, when you are answering such type of question, you have to know the proper concept so that you can make your answer. Now come to our next question. All are the components of curve 65 except confused state, option A, option B, respiratory rate more than 30 per minute, option C, blood urea nitrogen value greater than 7 millimole per liter, and option D, systolic blood pressure less than 100 millimeter of mercury. So go through the option carefully and answer the question. Here the right option is systolic blood pressure less than 100 millimeter of mercury. Now let's dive into the explanation. Curve 65 score is usually related to the community acquired pneumonia. It is a particular scoring system that can predict the mortality outcome of the patient with CAP, that is community acquired pneumonia. another scoring system related to CAP, that is the PSI score, or the pneumonia severity score. So let's see the components of the CARP 65. Each component having 1 point. So confusion, new onset confusion, urea more than 7 millimole per liter, respiratory rate 30 breaths per minute, more than 30 breaths per minute, blood pressure SVP less than is equal to 90 millimeter mercury, and DBP, the diastolic blood pressure, less than is equal to 60 millimeter mercury, and the age more than is equal to 65 years. So here you can see that the option D, that is the systolic BP less than 100 millimeter, it is wrongly given. Okay. So this is the wrong option. Actually it is less than 90 millimeter of mercury. So we can make the scoring system, and through the score we can formulate the risk assessment. Okay, so higher the points, higher the risk. Points 3 to 5 means the 15 to 40% mortality, and in such patient, consider ICU admission immediately for proper management. And option and the score between 0 to 1 points, they are low risk patient, less than 3% mortality, and then they can be treated in the outpatient basis. Okay. So this is actually a recall based question, but for your daily clinical practice, you should know such type of score, and you should memorize those scores properly so that you can manage your patient in a protocol oriented manner. And definitely, as they are very important for your day-to-day clinical practice, this type of question used to offer in the they are the favorite question for the paper setters in the NEET PG. So come to our next question. A 22-year-old female patient came with complaints of vomiting and a decrease in movement in the right leg. In the past, she has had episode of violent and aggressive behavior and abdominal pain. Which of the following is the most probable diagnosis? Option A, AIDP with migraine. Option B, the right-sided paralysis. Option C, acute intermittent porphyria. And option D, conversion disorder. So here the right option is the acute intermittent porphyria, that is option C. Go through the symptoms. 22-year female, old female. What are the complaints? GI complaint, vomiting, and the abdominal pain. Neurological problem, decrease in the movement of the right leg. And the psychiatric problem, that is related to the past history of episodic, violent and aggressive behavior. So all such problems can be correlated with acute intermittent porphyria. Typical classic triad, abdominal pain, more than 90%, seen in more than 90% attack. Usually it is severe, diffuse and often colicky. Psychiatric symptom, agitation, hallucination, aggressive behavior as stated in the question. Neurological symptom, peripheral neuropathy. Actually, peripheral neuropathy related to the acute intermittent porphyria is due to the axonal degeneration, not due to the demyelination. Motor weakness, other neurological symptoms, seizures and autonomic instability. So as you all know that acute intermittent porphyria is a inheritance disorder, and it is the autosomal dominant condition, actually resulting from the half normal level of the HMB synthase activity. So as you all know that there are two types of porphyria. Acute intermittent porphyria is also called the hepatic porphyria. Actually, in broad classification, porphyria are of two types: hepatic porphyria and the erythropoietic porphyria. And the hepatic porphyria having the 5 types. Number 1, ALA dehydratase deficiency. Number 2, AIP, that is the acute intermittent porphyria. Number 3, porphyria cutanea tarda. Number 4, hereditary coproporphyria. And number 5, the variegate porphyria. And if you come to the next part, there is the erythropoietic porphyria. It is having three types. That is number 1, X-linked sideroblastic anemia. Number 2, congenital erythropoietic porphyria. And number 3, the erythropoietic protoporphyria. So all those are the types of porphyria. Actually, acute intermittent porphyria is characterized by the neurovisceral attack without cutaneous photosensitivity. And its classical presentation involves the young female with the said triad of symptom. Okay. So normally patient with acute intermittent porphyria is asymptomatic, and number of things are the precipitating factor, and the common precipitants are the drugs like barbiturates, sulfonamides, OCPs, and anticonvulsants. Memorize properly all those drugs. Hormonal like menstrual cycle in luteal phase and the pregnancy. And the metabolic part that are related to fasting, low carb diet, alcohol, infection, and stress. During the acute attack, what should be the management strategy? Usually we start with the narcotic analgesic for the relief of the abdominal pain, and phenothiazines can be used for the nausea, vomiting like symptoms. Intravenous glucose therapy can be started, and those who are unable to take the oral medicine, the parenteral regimen is better option. Actually, intravenous heme therapy is better than the IV glucose therapy for rapid recovery. Okay, so all the particular significant things you have to know related to the acute intermittent porphyria so that you can crack your future NEET PG questions related to that particular topic. Okay, so here why the other options are incorrect. AIDP or Guillain-Barré syndrome presents with ascending paralysis but lacks the severe abdominal pain and psychiatric feature. And conversion disorder, also known as the functional neurological disorder, is a diagnosis of exclusion and doesn't explain the full organic picture. So here is the next question. A 43-year-old patient presented with spikes of fever and difficulty in breathing. Transesophageal echocardiography revealed the vegetation in the heart. The culture was positive for Burkholderia cepacia. Which of the following is the first line of management? Options are aminoglycoside and colistin. Option B, the co-trimoxazole with third generation cephalosporin. Option C, cefepime and tigecycline. Option D, carbapenems and third generation cephalosporin. So go through the options and solve the given question. So here the options, the correct option is option B, the co-trimoxazole with third generation cephalosporin. Let's crack the diagnosis. See the question carefully. 43 years old patient. The symptoms are spikes of fever and difficulty in breathing. Echocardiographic finding, transesophageal echocardiographic finding, that is vegetation in the heart. And the culture positive for Burkholderia cepacia. So diagnosis is bacterial endocarditis induced by Burkholderia cepacia. So Burkholderia cepacia is a multi-drug resistant gram-negative organism under the Pseudomonas family and often associated with the cystic fibrosis. Yes, The patient with cystic fibrosis are more vulnerable with this type of pathogen. But it can also cause a serious infection like endocarditis in immunocompromised patient or the IV drug user. So remember the septicemia syndrome. It is a rapid fatal necrotizing pneumonia with bacteremia. Usually occurs in the immunocompromised patient. And regarding the management strategy, because the BCC is intrinsically resistant to many common antibiotics, treatment is difficult and usually requires the combination therapy. So what is the first line of agent? Trimethoprim sulfamethoxazole or cotrimoxazole. It is usually the backbone of the therapy. Other drugs used are ceftazidime, that is the third generation cephalosporin, meropenem, and the minocycline. But in case of bacterial endocarditis, like this, and like in the set question, the combination therapy, that is the cotrimoxazole with third generation cephalosporin, is typically recommended. So let's discuss why the other options are incorrect. Aminoglycoside and colistin. They are intrinsically resistant to aminoglycoside and often resistant to colistin. And tigecycline, not a first line of choice for B. cephacea endocarditis. So here is the bullet point: Burkholderia cephacea, aminoglycoside resistant, and the TMP SMX sensitive. So mind it and remember it properly so that you can solve this question in a better way. This is all about our today's session. Welcome to AiMedTech. I am Dr. Ratul Basu. Stay focused, stay strategic. Will be coming soon.